I am so honored to be part of this program, and not a problem. I normally get up at 4 anyway, so the timing is not an issue. But I really do, I'm honored to be able to participate in this meeting. And it's interesting to see the sarcoma presentation and the pancreatic cancer presentation, because the study that I call Shipp, which stands for stereotactic heavy ions versus protons versus photons, is for prostate cancer. And many people say, you shouldn't be doing prostate cancer. In fact, the most common site treated with carbon in the world has been prostate cancer. And it's a very common disease, and we have biomarkers that we can use to monitor responses. We have the blood test, the PSA. We have validated quality of life metrics that are readily accessible using International Prostate Cancer Symptom Score. We have a test for sexual function. So in many ways, it's a common disease. It's a disease that we can measure the outcomes with in several ways, and it's being treated with carbon. So today I'm going to talk about the schema of the study, the endpoints, collaborators. I'm not going to spend a lot of time on radiobiology. I'm a clinician, and I'm going to talk about some of the challenges going forward. Now, I changed the order of my slides slightly, just so those of you who don't know me, I'm a clinician, and I've done, if we were able to get Shipp open, it would be my third randomized trial. My first trial was RTOG 9413, which involved 1,200 patients, which we reported with the median follow-up of 14 years in surviving patients. We've reported those results out. The next trial, RTOG 0924, is a randomized phase 3 trial that compares field size and stratifies. It's for unfavorable, intermediate risk, and high-risk prostate cancer. And this is not an up-to-date slide. We completed the study accrual with 2,592 patients. The study closed in June of 2019. It opened up in 2011. So unlike rare diseases like sarcomas and difficult diseases to treat like pancreatic cancer, we have over 2,500 patients completed, recruited, and we're waiting for the analysis, which is supposed to take place next year. But the main point here is that I have designed and run very large trials. The Shipp study would be the first phase 2 study, a small study, a proof of principle study. This is our simplified sort of design. We have a number of institutions. People are online who are responsible and have agreed to collaborate with us. Dr. Hoppy, I've known for some years, is going to probably build the first carbon center there at Mayo in the US. So they're involved. We have people that have protons available. And then, of course, we have a number of carbon centers. And the bottom line is that this is a randomized phase 2 study, not a matched comparison, randomized phase 2 study in which patients would be randomized between carbon, protons, and photons. And this is stereotactic body radiotherapy. So of treatment, we're talking about potentially 1 week of treatment, like Monday, Tuesday, Thursday, Friday, done. And the idea would be that we would do the planning before the patient went to the carbon center, sending the imaging, DICOM compatible, all the stuff. But anyway, but a relatively small study. We have, I'm not going to dwell on this a lot. We have defined different types of centers. Type 1, a type 1 center would be a center that had photons only. That would be a UCSF, for example. A type 2 center would be a place that has protons. Either 2A is protons only, 2B would be protons, photons, and 2C would be protons, photons, and carbon. So all three, that would be like Heidelberg. And then we have places that are carbon. Type 3A is carbon only, and the randomization is not exactly 1-to-1. It ends up being 1-to-1, but the way that we've structured it is that when you enter a patient on a study, you have a 90% chance you're going to keep the patient. So patients that go to a carbon center, the randomization is matched in such a way. We only have 4 carbon centers, but we want to recruit the number of patients, so they're more likely to stay at the carbon center. So it's a different kind of randomized study design. The specific endpoints, I'm going to not go line by line by line, but just to make the point that the first aim has to do with QA. Can we accurately define what we're doing, where we're doing, how we're doing it? And then after that, the next aim has to deal with the trial design. We need consensus among the investigators as to how we're going to treat the patient. Is it 4 fractions, 5 fractions? And then we would, the endpoints are safety endpoints. Can you show that carbon is just as safe as protons and photons using 4 or 5 fractions? And the primary endpoints would involve quality of life metrics. The International Prostate Cancer Symptom Score is a validated patient-reported outcome, not physician-reported, and I'll talk about that later. And then SHIM is the sexual health inventory. So we have quantitative ways that have been validated repeatedly in which the patient determines the outcome. And then we have secondary endpoints, which would be the PSA kinetics. What does the blood test, the PSA, prostate-specific antigen, this biomarker that we use to determine failure, what does that thing do after you radiate, and how low does it go? Then we would take the information gleaned from the AIM-2 and then see how that jives with the radiobiology. And I'll talk a little bit about that next. So here's sort of a timeline that we have put together. This timeline actually matches well with Mayo. You see we mentioned them down below. We're hoping that by the time we finish the study design, the QA, and get it all IRB approved in international countries, that then Mayo would come aboard, and so we would have a site in the US. But we could go on even if Mayo wasn't open for carbon, because we would start even ahead of time. We're going to use stereotactic body radiotherapy, meaning short courses of treatment. And this is something that the biologists may want to come back to later. And for those of you who don't do this, I do this routinely. In this case, this is how we use the so-called cyber knife, but you can do it with the LINAC as well. We have 3 gold marker seeds placed in the prostate. We do a CT-MR for planning. We do CT-MR fusion. And then we use hundreds of beams to deliver very elegant dose distributions. And we actually did some measurements at Heidelberg looking at the potential for urethral sparing. So the principle here is that both carbon and protons, if properly applied, might have a dose distribution advantage in terms of sparing the urethra, the bladder neck, and potentially the penile bulb, which could affect erectile dysfunction. So we think that if we could do it properly, we might be able to show an advantage to these two particles. This is from a review article we wrote on stereotactic body radiotherapy, looking at the toxicity. It's now moved into sort of standard of care, and it's very well tolerated compared to other modalities, whether you're talking about HDR or permanent implants or dose-escalated external beam radiation. And there are other population-based studies. This is one looking at results with low and intermediate risk. Our focus would be unfavorable intermediate risk prostate cancer, for which there's a need for some improvement. This is a summary of studies looking at stereotactic body radiotherapy in patients with unfavorable intermediate risk prostate cancer from the literature. And what you see is that the recurrence rate is anywhere from 20 to 25%. When you radiate these patients. These unfavorable intermediate risk means your PSA is between, when you have multiple unfavorable features, but you're otherwise favorable, more than half of your biopsies are positive. If you have what's called a Gleason score, which is 4+3, or if your PSA is between 10 and 20. So we have very reasonably well agreed on criteria for unfavorable intermediate risk. And these patients seem to need more than just local X-ray treatment. This is from a study that Dr. Vargas, a randomized trial actually looking at protons in 5 fractions versus 44 fractions, showing how well tolerated it is. So we know that at least, there's some data, at least, randomized looking at toxicity that suggests that they're comparable. And then we have the long-term results, which I'm sure were presented over the last few days from the Japanese experience with carbon, suggesting that carbon had good effectiveness. But of course, we would, if you look at this curve, you can see that there were still biochemical failures and similar sort of results to what we reported, about 20% recurrence rate at 5 years. So they may be slightly lower. So we would, this helps form the basis for our study design. And then you have the randomized trial that was conducted at Heidelberg. This was the first trial, randomized phase 2 of carbon versus protons. And when it was first published, this is in 2016, they had 91 patients. And what you can see is if you just look at grade 3 toxicity, you can see as you take grade 2 and grade 3, approximately 13% versus 2%, suggesting that carbon might be less toxic. Diarrhea, 8.7 versus 0 for grade 2, and cystitis, 21.7 versus 13. So, wow, you're looking at this and you're saying, what, carbon might, this might be consistent with what some of the Japanese literature suggested. However, the investigators at Heidelberg subsequently published their updated results, and I'm going to skip ahead for a second. And basically what they showed was that the patients who were treated with protons did better, had better biochemical control than the patients treated with carbon, which was different than what we would expect. And it turns out that this is being explained by the investigators as being related to assumptions about the model that was used. LIM1, a carbon with an alpha beta of 2 versus 4. And if you used a different alpha beta, if you used a different alpha beta, it turns out that the doses that were being given with carbon were lower. The biologic doses were lower. And that would explain why the toxicity with carbon was lower and why the biochemical control rate was lower. So one of the things that we wish to do in Shipp is to look at whether or not we can adjust for these assumptions and create a more accurate way and make sure that in our trial that we don't underdose with carbon. Now, so the idea here is that you have the rectum behind the prostate, you have the urethra there, and the idea that we can spare some of these structures and potentially reduce the toxicity of carbon therapy. So I consider this a feasibility study. I talked about the importance for QA, but the question is, if we could launch a relatively small, by prostate cancer study sizes, international study by doing the QA, and as was alluded to by the previous speaker, part of the issue is the funding model and travel and cost abroad. And we actually created an equation that said, okay, it depends on the number of patients, but it also depends on the cost of treatment. They're different. The prices for carbon in Japan and Germany and other places are different. The cost of travel can be different. The number of days, we would shorten it down to 1 week or so if we could. And you can act, and then also vendor support. So this is a feasibility that takes into account how much the NCI gave us per case reimbursement, how much vendor support we got, how much nonprofit, how much the insurance would cover. The Medicare actually has a policy that they would reimburse certain centers for protons if the patient was treated on a clinical trial. So we hope to, by launching this trial, have the insurance companies in the US be willing to pay some of the expenses for the trial, as well as the NCI. And so the very favorable would be if the vendors put in money. So this is a per case kind of analysis, but the bottom line is it could be very feasible if we got vendor support, but not as feasible if we didn't. And it also depended upon the reimbursement by insurance companies and how much the NCI gave us per patient. So in terms of quality of life endpoints, I've alluded to these. We use these validated instruments. We use these biochemical markers, and then we would come back and use models to assess the outcome. We rounded up the usual suspects in terms of carbon centers, and we have the support. I have to credit the people at UT Southwestern because they're the ones that helped get IROC into QA for carbon. And so we would utilize that infrastructure to help us with our trial to do the QA stuff, and we would address these models. Now, I'm going to shift and talk about a competing technology, and it's relevant for two main reasons. One, the concept of trial design in general and the problems with randomized trial design, and potential biases that you want to avoid, and also will confront the issue that some people might think that by comparing photon-based SBRT, we're using something that might be obsolete in the next few years because of things like this randomized trial, which is using an MR-guided LINAC versus what they call a CT-guided stereotactic treatment. So this is a phase, I guess it's a phase 3 or 2 randomized trial that was published in JAMA in January 2023. So this was, their objective was to compare MR-guided stereotactic radiotherapy and whether it improved acute, now this is key, physician-scored GU toxicity when compared with standard CT-guided SBRT. And also they would use as an endpoint CT, CAE. These are standard criteria that you use when you do physician-reported using those outcomes. The intervention was a 1-to-1 randomization. And this is key as well. For the MR-guided, they used, for the CT-guided, they used 4-millimeter margins. And for the MR-guided, they used 2-millimeter margins, and they gave 40 gray in 5 fractions. And the results, the study was closed to accrual early because they reported that the acute grade 2 or greater GU toxicity was significantly lower with MR. So there's less morbid compared to CT, 24% versus 43%. The incidence of greater than grade 2 GI toxicity, 0 versus 10, and a significantly smaller percentage of patients with a 15-point or greater increase in symptoms. So they concluded that in this randomized trial that got compared CT guidance versus MR guidance, that MR guidance was better. And so the question is, if we do a randomized trial of what might be called CT guided versus protons versus carbon, would this be a problem? And so I'm going to speak to the study. So the randomization was approximately the same size as what we're proposing, but we would propose 3 arms versus 2 arms. And but let me just make several points. First of all, they call this MR guided versus CT guided. And in fact, both the so-called CT guided and the MR guided were based on MR images. So they did 3T or 1.5 Tesla MRI, and they defined the target volume. And then what they did is they used a 0.35 Tesla LINAC to do their image guidance, and they used fiducial markers in the prostate to guide the treatment. So it wasn't really CT guided, it was fiducial marker guided. This is a paper this is the first comparative paper of CT versus MR published in the literature. I wrote this paper in 1996. It's important to use MR guidance because CT makes the prostate look 30% larger than the MR, at least at that time. when we learned how to better correlate CT with MR, it became less of an issue. But just having the naked eye look at a CT and MR, there's a tendency to make the prostate look bigger. But also a very old study that we published about 20 years ago now was there used to be a device called the BAT, B-mode ultrasound device. And 20 years ago, we basically put this company out of business because everybody was buying these machines to do image guidance. So they had an ultrasound device that they would put over the abdomen and every day guide the treatment. And it turned out that we proved that because of inter-observer variability, that in fact, this image-guided approach didn't work and was not as accurate as using fiducial markers. So the first question is, well, that's not the first question, but an important question is, how accurate is a 0.35 Tesla image-guided approach for treating prostate cancer? And so you have 3T MRI for both. We're using the fiducial markers to guide with CT, and we're using no fiducial markers in the MR guidance. And you have to recognize that they did an automatic beam hold adjustment that was initiated if greater than 10% of the prostate moved outside of a 3 millimeter gating boundary. So although they say they were doing MR guidance, they only moved it, they only adjusted for it if more than 10% of the prostate was out the 3 millimeter margin. With the CT guidance, we're treating the patient, we're setting them up within one or two, to treat them within the accuracy of 1 or 2 millimeters. So here's a thought experiment. Suppose you have two identical MR linacs, and you treat one group of patients with 2 millimeter margins, and the volume that's irradiated is 70.55 cc's, and you treat the other group of patients with 4 millimeter margins, and the irradiated margin is 102.1 cc's, and you get more side effects from the one that you use 4 millimeter margins. You cannot possibly argue that this technology that used the 4 millimeter margins is worse, because you've created an artificial circumstance in which the volume that's being radiated is greater in an arbitrary way. We showed 20 years ago, you don't really need to use uniform margins anyway. You need to put smaller margins at the interface of dose-limiting structures. So when you do the comparison of the 2 millimeter margins versus 4 millimeter margins, and you have a linac, conventional linac versus this MR guidance, you also have to take into account that the MR linac delivers the treatment over 1,133 seconds compared to the CT, which is 232 seconds. Which means that the patients on the MR linac are on the table 5 times longer, which gives the prostate more time to move and more time for the patient to move. And then they're only adjusting for it if greater than 10% of the prostate is outside the field. But since they did not report any clinical outcome in terms of survival or biochemical control, which probably wouldn't be different, a short follow-up of so many months, to argue that this is better, that the MR guidance is better because there's more toxicity is problematic from my perspective. But it gets worse. So we know that the doses that they chose to use were 40 gray. And if you look, there's a 6,000 patient meta-analysis published by Jackson et al. And approximately 90% of the patients in the 6,000 cohort receive doses of less than 40 gray. For example, my standard dose is 38 gray. There are other people that use 36.25, I think is the most common dose with 5 fractions. But they also allowed the investigators to use even higher doses at their discretion, delivering a simultaneous integrated boost to the dominant interprostatic lesion that is 42 gray in 5 fractions, and to boost any PET-positive pelvic nodes that were identified. Now, I'm digging into the details of the study in part because these are the sorts of issues that we would be confronted with when we design a study. We have to say, well, what are we going to leave? What will we allow the investigators to do? What discretion will they have? And in this case, they allowed this discretion, and they did not stratify this in a trial. And as I'll show you, that there were more high-risk patients on the CT arm with a higher absolute number of risk factors likely to impact GI toxicity. This could create bias favoring the MR arm. So from their appendix or supplement, they provided this data. So if you look at the percentage of patients that had high or very high risk, there were 39% versus 25. And that means that these patients were more likely to be given the extra boost or to have their pelvic nodes treated to get the 42 gray. And in addition to that, fewer of them received rectal spaces. I'm not sure rectal spaces work, but the fact is that fewer of them received it. And if you looked at baseline GI comorbidity, there were it was more baseline comorbidity before they ever got treatment on the CT group. And so if you added up all of these potential factors, you would say 93 potential adverse factors in 77 patients that got CT guidance versus 74 in the MR guidance patients. So whenever we design a study, we have to be prepared to look back and say, wait a minute, did we do it properly? They should have stratified by some of these variables. I'm gonna just spend a moment because this is important for some of our studies that have been talked about and for the study that I'm proposing. This is looking at observer bias in randomized trials with measurement scales. This is a systematic review of using blinded and unblinded assessors. So this is an important concept when we talk about clinical treatment. So this paper is really useful. They did a systematic review of randomized trials in which there were blinded and unblinded assessments of the same measurement scale outcome. And they were able to find 16 trials that involved 2,854 patients with some subjective outcomes. And they found that treatment effect was more beneficial based on unblinded assessors, exaggerating the pooled effect size by 68%. So the investigators that are unblinded, it affects them. And so it's important that these sorts of studies be done properly. And here's the data just showing that the unblinded favors the unblinded results tend to look better. So in addition to that, this is also an important observation. So this is a study looking at what the patients are orange, what the patients report pre-treatment, post-treatment at different time points in terms of what their level of toxicity is. These are urinary endpoints here in this study and gastrointestinal on the other side versus the physician. So what this shows you is that when you do a study and you ask the doctor how many side effects the patient have, the doctor tends to downplay the side effects that the patient has. So the doctor reports fewer side effects than the patient. The patient goes, oh, no, I was having side effects. Yes, I was. But the doctor is like, no, he was doing fine. Okay, that's what the literature shows. But when you come back to the Mirage paper, and I've written a commentary that I've submitted to the journal, which I haven't heard back from, and you look in the supplementary materials, what you find is that when you look at physician-reported toxicity greater than or equal to grade 2 genital urinary, they reported more toxicity with the CT guided. Now, this is a single institution. They're the only ones who were using this technology to do this study. And of course, they report that their MR-Linac, which they are the ones that have this device, had less GU toxicity. But when you ask the patients on this study, they reported no, they did not, their response was lower they didn't see a difference. So this contradicts what the literature says about who's supposed to report more. And it also raises questions about in an unblinded assessment, when the physician has potential bias to make their results, I don't mean ethically make their results, but they're optimistic and actually may also influence the patient's toxicity level. So this is from another study. This is looking at the placebo effects. So this is from a University of Cincinnati study that tested both blue and pink stimulants and sedatives on students. These are medical students. Unbeknownst to the students, the stimulants and the sedatives were all placebos, but the blue placebo sedative was 66% effective compared to 26% for the pink ones. Both placebos were around 2.5 times more effective for relaxation than the pink one. So the blue placebo was better, and this is placebo. So now you got to think back at this trial. You randomize patients and you tell the patients, you're gonna get treated on an MR guided. This is new technology, and we'll be able to use 2mm margins. And you tell the other patient, we're gonna treat you with standard SBRT with 4mm margins. That could have an effect on what the patient says about what their toxicity was. They may underreport their toxicity with the MR-Linac. So I believe the Mirage trial was a flawed design. They made arbitrary decisions about the margins and doses. They made some, it never was CT guided SBRT, it's fiducial marker guidance versus MR guidance using a 0.35 Tesla device without fiducials. There's potential evidence of bias, many opportunities for bias. They have no clinical outcomes, and we know that one is substantially more expensive. When I come back to the Shipp study, we need a well-designed study with centralized QA, with rationale for doses, consensus of margins, deal with motion adjustments and fiducial guidance. We need to minimize potential biases and eliminate opportunities for placebo effect and report clinical outcome. So I'm going to stop here with this last quote. I skate where the puck is going to be, not where it's been. I think this is what the Shipp trial does. More people have moved. There's a recent article that's going to be coming. There's many studies that show that stereotactic body ultra hypofractionation using just a few fractions is becoming the norm. And so we need to look at, are any of these particles superior to X-ray based stereotactic treatment? So I'm gonna stop sharing there and see if I can answer any questions.
Thank you so much, Professor Roach, for that really great lecture on the Shipp trial. I am not seeing any questions on the Google Sheet. Let me see, are there any questions on the chat? Yes, we have a hand raised by Professor Galalay. You have the floor, Professor.
Thank you very much. Well, fantastic lecture. Thank you so much. We have discussed that issue also in a small round. And I think it's indeed very important to agree before start such a trial on everything, on each detail. I think what would also be, I don't know if you heard my lecture a few days ago.
I did not, unfortunately.
Okay, so I think we have to agree on clear definition of GTV, CTV1, CTV2, and so far. Because you just showed now very importantly that in this trial, MRI versus CT, the definition of the volumes was indeed quite different. I think that doesn't make difference to do such a trial. So I very much agree with you. So this is the only point I wanted to add. Thank you very much for the great lecture. I hope we can cooperate together in the future.
I'm sorry I missed your talk. The time difference here.
No problem. I can send you the PDFs and then we can discuss that.
I'd appreciate it. I really would. Yeah, I think it's really important that we do trials well.
Yes. Thank you so much.
Incidentally, all the lectures have been recorded and are made available via YouTube on the HITRIplus website. Professor Roach, I will send you a link of Professor Galalei's lecture.
Perfect, thank you.
Okay.
Send me a link too.
Of course, Professor Hoppe, of course.
Yeah.
Okay. I'm not seeing any other questions.